to finish up these couple things on hypotension. I had a couple announcements, but it's pretty sparse this morning, so I might wait on those just a few minutes.
Oh, yeah, it is.
But yeah, it's actually, that clock is 3 minutes fast, but I have 8, so I'm going to go ahead and go. So hypotension is kind of where we left off last time. And with hypotension, that's the opposite kind of hypertension, obviously, so it's low blood pressure. And, you know, some people do just kind of have lower blood pressure to begin with. Exercise, good cardiovascular health will all keep your blood pressure down low. As we get older, it's absolutely normal for your blood pressure to keep climbing. Generally, adults, though, we wouldn't see anything less than maybe 90 to 100 over maybe 50 to 60. And then, too, we look at symptomatic. So if the adult is symptomatic with the low blood pressure, that becomes our biggest concern. And what do you think those symptoms would be if they were symptomatic with low blood pressure? What would you see in them?
Dizziness?
Dizziness, fainting, when you stand up. Have you all done that where you like get up too quickly and you're like, whoa?
Yeah.
So that response is about your baroreceptors. And so your baroreceptors sense when you stand up and they're supposed to tighten. And that's supposed to support that blood pressure. As we get older, that response takes longer. So the older adult, we a lot of times tell them to, when they get up in the morning, sit at the side of the bed for a few minutes and let those baroreceptors kick in, then get up and walk. Our biggest concern is falling. And fall risk is the #1 problem that we're concerned about with low blood pressure. Treating low blood pressure is actually fairly hard. And really one of the best ways to treat low blood pressure is, what do you think? What would help? Well, sodium with
Water.
fluids, yeah. So, and a lot of times people become low blood pressure because of loss of fluids. But the older adult, if they have heart failure, then they may not be able to take on extra fluids. So these are your symptoms here, that dizziness, the syncope, falling, and then here is your criteria, and you hopefully learned that in health assessment, and that's the criteria of what?
Orthostatic hypotension.
Orthostatic hypotension, okay? And we primarily see orthostatic hypotension when patients have dehydration. That's usually when we see it. So when a patient comes into the ER or has been vomiting or diarrhea or something like that, that's what we're kind of checking for. And if we think they have orthostatic hypotension and they have been having vomiting, diarrhea, things like that, then what we can just do is give them fluids, and that usually helps because it expands the volume and those expand your preload, and that's our big issue there. Low blood pressure is common in the elderly because of that baroreceptor response is not strong enough and it takes a long time. Also, what do a lot of the elderly take?
Diuretics.
Diuretics and blood pressure medications. And so they may need the blood pressure medications, but yet when they jump up and get up really quick in the middle of the night to go to the bathroom, they still need to give themselves some time. So it's kind of hard to balance that. We can also have hypotension and fainting and syncope from vasovagal. Have you ever stood in the shower, a really hot shower, and all of a sudden you get kind of woozy? I had a daughter that did this all the time, and we would just hear clunk, clunk, clunk. And we'd yell, Rach, you okay? And she'd be like, yeah. Okay, and I'm like, turn the shower down, honey. It's a little too hot for you. So sometimes you can kind of get that vasovagal, and that can do it. Also, your older adult who's trying to poop really, really hard and sitting on the toilet, and they bear down, they can vasovagal down, and they can cause some of that as well. So always kind of keep an eye, especially that constipated person who's bearing down like crazy on the toilet. They'll fall right over and faint. Dysrhythmias can cause low blood pressure because every heartbeat produces cardiac output. And so that's actually one of, when we talk about dysrhythmias, that's one of the things we'll talk about Are they dizzy? Are they having signs of low blood pressure, not enough perfusion, and loss of cardiac output? And then we have to treat their dysrhythmia. Drugs, alcohol, vasomotor center neurological problems can cause that too, because your blood pressure is controlled in your brain, and then sometimes endocrine disorders. As far as treatment, like I said, it's super, super, super hard to treat low blood pressure if you can't give fluids. Fluids is the #1 thing to do, and if they have some kind of contraindication to fluids, like they're in heart failure, then we're not going to be able to add more fluids. So we have to do other things, like tell them to get up slowly, balance their medications, avoid these really hot environments, and then avoid this large carbohydrate meal. Have you ever done that one too, where you eat a whole, like you couldn't stop the bag of candy or the bucket of Kentucky Fried Chicken, and all of a sudden you eat something and you have to like run to the bathroom and you just like, it all goes right through you? Sometimes that happens too if you eat a large meal of one type of component. It will pull fluid from other parts of your body, and your gut will literally just send it right through. It'll just go right through you, and that'll pull that fluid and cause some low blood pressure too. So that's not an uncommon thing for some individuals as well. We call it, actually, it's got a name. It's called dumping syndrome. And it's exactly what I just said. You just dump everything out. One thing is sometimes if you get dizzy, you bend forward or squatting. What that does is it cuts off the circulation to the lower extremities to boost the blood pressure in the upper area. So that's why we tell people to bend over, or some kids, little kids, will actually just squat on their own. They'll learn to do that. Elastic compression stockings can help some, but not that much. Let's look at this question, and then we're going to bump on to our next thing. So as part of a routine physical, a client had their blood pressure checked. It was found to be 170 over 100. Client's 53 years old, 5'10", weighs 230 pounds, and is male, sex assigned at birth. Serum cholesterol is 265, LDL is 170, HDL is 24. The client's father died after a second heart attack. Which of the following statements regarding the client's hypertension diagnosis is true? And there is a lot of information in there for you. So first of all, is the only risk factors modifiable ones? No. Let's cross that out. Looking at that blood pressure, this situation, do you think lifestyle modifications would be sufficient?
No.
Probably not. His hypertension is classified as secondary.
Yes, it is.
Multimodality treatment is indicated. Which one is? Why would you say his hypertension is secondary?
Because of cholesterol, high cholesterol, and
Yeah, so this is actually the answer. This is actually idiopathic primary hypertension. Okay, this is primary hypertension. There's nothing in here that says he has another disorder. The cholesterol is part of the cardiovascular disease. Okay, and high cholesterol alone is not really, when we talk about secondary hypertension, we're talking about kidney disease causing high blood pressure, a treatment causing high blood pressure. These things right here, the high cholesterol alone isn't necessarily causing high blood pressure. So your best, when you get down to these two, you got to kind of think about what is your best answer. And the fact is that this guy needs a lot of things done. Okay, he's got a lot of stuff going on. All right, after jogging 5 miles, the client feels dizzy and thirsty. Blood pressure is low. Which of the following recommendations is most helpful? Make sure the whole answer is correct. What about this cold washcloth on the head? It's nice, but is it going to help the blood pressure?
I don't think so.
Yeah, that's not going to help me. Have her drink a large glass of water.
Yeah.
Yeah, okay, with this one we're kind of thinking about.
Mm-hmm.
Have her take a shower with cool water.
It's kind of like the first one.
It's not going to do a thing for her blood pressure. Make her feel better, maybe, but not necessarily. Encourage her to sit down and take a cold, deep breath.
I don't know.
What does that mean? Okay, this is stupid. All right? So this is nice. Yeah, have her sit down. Cold, deep breath? That's dumb. That doesn't even make sense. That's one of my stupid things. Okay, so let's do this. And why is drinking going to help her?
Fluid.
Increase fluid volume.
Right, because she needs a fluid volume. All right. Let's see here. Okay, we're going to go right into cardiac stuff. In-class cardiac, I think this is it. Yep, and hopefully, I had checked this morning, and quite a few of you had done, at 7:15, had submitted your pre-work. So I assume the rest of you did too. But that's going to be really important for today because there was a lot of information in there. That's going to kind of help us go on. So this is our outline today. We're going to talk about coronary artery disease. Now your coronary arteries, what are they again? What do they supply?
The heart.
The heart muscle. That is important. They just surround the heart muscle. And if you aren't getting blood through them, then the heart muscle itself can't get blood and oxygen. If the heart muscle can't get blood and oxygen, what's going to happen? What happens when you don't get blood and oxygen? Ischemia and maybe infarction, death. Okay, so that's coronary artery disease. Our primary thing here is going to be a heart attack. And we're going to call it acute coronary syndrome. Cardiomyopathy, we'll talk about that. That's a weak heart muscle. That's a heart muscle that's flabby and weak. Infectious disorders, so things that of infectious nature that hurt the heart. Valve disease, and we're only going to talk about mitral and aortic valve because those are our biggest players. They're on the left side of the heart. And remember, what is your main pumping chamber? The left ventricle. And then disorders of the pericardium, which is the surrounding of the heart. All of these things usually result in heart failure. So that's kind of the end result. That's the end stage. And then congenital heart disease, and that's anything born with an abnormal heart. So ischemia versus infarction. We've talked about this a bunch of times. Ischemia means there's not enough blood flow. And what symptom do you get if you have ischemia? What do you feel? Yes, you feel pain. And if there's ischemia in the arteries, we're going to call it chest pain. And what's our special name for chest pain? Angina. Okay. Now remember when we talked about intermittent claudication? How when we demanded activity and we didn't get enough, it hurt, and then we stopped, and then the pain went away? Okay, this is the same principle with angina, except for it's heart. You don't get enough blood flow, and with the angina, hopefully, if you stop the activity, the pain will go away. That's what we're going to call as stable angina, goes away. If it's unstable, that means it's not being relieved with rest, and that's going to be a problem because what does that mean? If the pain's not relieved with rest, and it's chest pain, what is that telling you?
Not getting enough blood to the heart.
Yep, and that's going to be infarction. And that's our worrisome thing here. Infarction. Which one of these is reversible?
Ischemia.
Yep. And which is irreversible?
Infarction.
Infarction. Okay. So the causes of reduced coronary artery flow. What can cause you to have decreased blood flow in those coronary arteries that are surrounding the heart? Every time your heart pumps, blood goes out to the body, and when it relaxes, those coronary arteries fill and get blood to the heart. So plaques, and we've talked about plaques, right? That's where the lipid builds up, and sometimes that plaque is stable, meaning blood is getting through it and it's nice and stuck in place. And sometimes it's unstable. What does an unstable plaque mean?
It can move, travels.
Yeah, it's too big and it's not hardly fixed, and so anything can cause it to start to rip loose and flap. Now the flapping of it inside the artery can cut off blood flow to wherever it's going. But what also happens when it rips off?
It'll bleed.
It bleeds and platelets collect there. Which is why, have you ever heard when you have a heart attack, you take maybe an aspirin? Okay, that's to reduce those platelets from sticking there, and maybe a little bit of blood can get through that little flapping thing. So our biggest worry is plaques. And we can have stable plaques, which are going to cause more ischemia, and then unstable plaques are going to be more in risk for infarction.
Excuse me. Thank you.
So this platelet aggregation causes a thrombosis or a clot. So are you starting to get the lingo down, and you're starting to be like, okay, so when people talk about all this stuff. We also have this problem of you can cause decreased coronary artery flow from vasospasms. These are the same mechanisms we talked about last week with the rest of your body, right? Now we're just talking about them with regard to the coronary arteries. So the one thing about this class is that we keep building. Once we get halfway through this class, you know a lot more, and a lot of the stuff we talk about is just building upon. So once we get halfway, you're like over a hump, and we just keep adding on. So this next module, though, is still kind of rough. But once we get over that second module, you know a ton, and we just keep building. All this stuff with plaque, we're going to apply it again to your brain for stroke. Okay, so once you learn a plaque, they can be anywhere. So vasospasms, that can happen too. And remember, people just are spazzes sometimes, and that just happens. There's not a lot we can do about that. So sometimes with a vasospasm, that's a special time. That's a special kind of angina called Prince Metal. And we'll talk about that again. Now the microcirculation endothelial cell impairment. Where were those endothelial cells? Inside the blood vessels. What damaged the endothelial cells?
Plaque buildup.
What?
Plaque buildup.
The strip.
Plaque buildup, but what else damages it?
Glucose.
Glucose makes it weak and bleed. What else?
Increased blood pressure. Or smoking.
Yep.
Smoking.
Smoking, increased blood pressure. All of those things make those endothelial cell walls kind of at risk for bleeding. So that's going to be a problem too. And then a drop in blood pressure. So remember, those coronary arteries fill, the blood squirts out of the heart, goes through the aorta to the body, and then when the heart relaxes, that's when the coronary arteries fill. But if you don't have enough blood pressure to your body, what do you think that does to your heart muscle? Yeah, it's not going to fill those either. My mom did have a heart attack. It was a really weird thing. She ended up throwing this weird clot. Her arteries were all clean, but she has really low blood pressure to begin with. And when I went into the ER and she was having this heart attack, her blood pressure, they had given her morphine for pain, but her blood pressure was only about 60. And it was July. What's the bad thing about July in the hospital? It's hot, but what's the bad thing about July in a hospital? Residents. Yeah, so I go in there, and the resident's like looking at the EKG, and he says, "Oh, I heard you're an ICU nurse." And I'm like, "Yeah." And he's like, "What do you think of this?" And I said, "I think if you're asking me, you need to call your attending." Okay, that's what I think. So anyway, but I look, and I'm like, her blood pressure is like 60. And like, yeah. And I'm like, so she's not perfusing her heart muscle. And they're like, "Oh, yeah, that's right. Oh, yeah, let's give her a little less of that." Because you have to have enough blood pressure to get the heart muscle that's starving, right? All right, so ischemia. Ischemia means that you have some decreased blood flow. It means that you're probably having some pain. It means that you have some plaque buildup, and this takes on years. You can also develop that collateral circulation that we've talked about. People who exercise, even though over time their blood vessels are getting a little narrower and a little narrower from this plaque, if you're regularly exercising, then you're giving your body opportunity to make collateral circulation or extra blood vessels. And so that's why we recommend exercise. So we have stable angina. And what is stable angina? If I ask you to define it, I say the patient has stable angina. What is that?
That gets better with rest.
Yep, chest pain resolves with rest. Okay, now that's not great, right? You're still having chest pain, but that means that when you make a demand on it and you back off on that demand, you have enough blood flow for rest. And that's at least something. So your heart muscle probably isn't going to die if you back off on that physical activity. Now, do you know what we give patients who have chest pain, stable angina? Yeah, we give them nitroglycerin. And sometimes these are our older patients who really have kind of a sedentary lifestyle to begin with. They really shouldn't be out there shoveling snow or cutting the grass. Or maybe they've had multiple heart attacks, and maybe they're not really candidates for surgery, or they're not interested in that. And so we can give them, when they start to have chest pain, we can give nitroglycerin. What does nitroglycerin do?
Vasodilator.
It's a vasodilator. And why does that help stable angina?
Because it's like
Because if you vasodilate, what does that allow? More blood flow to sneak around that plaque. Okay, so that's why that's helpful for them. So stable angina isn't great. It means that you have some blockages, but there may be a reason why we're not fixing that, and I gave you those reasons. This is where we're all really concerned. This is where we get our emergency stuff. What we call acute coronary syndrome. And actually the sudden should be right here. So when I make about 1,500 slides a semester. That's about what you're going through. So yeah, you are going to find some errors in there. Somebody wrote one on my evaluation one time that my spelling, my slides had spelling errors. I'm like, well, you write 1,500 slides, and I bet you're going to have some errors too. Okay, so with acute coronary syndrome is a collection of events. Okay, so there's a collection of things that are going on with acute coronary syndrome. So there's a couple things that can be happening, and that's what we're primarily going to focus on. There's about 3 different tracks that acute coronary syndrome can go down. But acute coronary syndrome means there's an obstruction of flow, and it means that you're going to have some chest pain that does not resolve with rest, and that's going to be a problem. So acute coronary syndrome includes these 3 options. It can be unstable angina, which is from an unstable plaque. And if I say there's an unstable plaque, what do I mean? What's happening? What does that mean to you? It's flapping, and is the chest pain resolving? No. Okay? So that means that the chest pain is not resolving with rest. That's a problem, obviously. All of these acute coronary syndromes need to go to the ER. Stable angina doesn't necessarily, if you have nitroglycerin and it goes away, it needs medical management. Your doctor needs to be aware of it. Then you can have 2 versions of a heart attack, a STEMI and a non-STEMI. Okay, so this one right here is called a non-STEMI, and this one here is called a STEMI. Have you ever heard of these terms? A few people maybe? Okay. So acute coronary syndrome needs the ER, and it's going to be one of these 3 things, and they all need to be treated. It's going to be either unstable angina, chest pain not resolving with rest. It's going to be a non-STEMI, which is also chest pain not resolving with rest. Or it's going to be a STEMI, which is also chest pain not resolving with rest. So what's the difference then? Well, there's no damage in unstable angina yet. A STEMI and a non-STEMI both have damage. And when I say damage, what do I mean?
Infarction.
Yeah, like there's infarction. Infarction's not reversible. Okay, so there's no infarction with unstable angina. But because that chest pain's not resolving, we need to do something. With non-STEMI, there is infarction, but it's not a complete, meaning a tiny bit of blood is sneaking through. Not enough. And so there is some damage, but it's not the full thickness of the wall of the heart. So it's still a heart attack, but it's kind of not as bad as it could be. And then we have a STEMI. That means there's complete total occlusion, there's no blood getting through at all, and it's the full thickness of the heart muscle wall that's dying. So when I talk about a non-STEMI, I mean non-ST elevation, and a STEMI means ST elevation. When I talk about ST elevation, what am I talking about? What am I referring to? The EKG, the last part. And so if you can see here, that is elevated ST. What elevated ST means is that there's no oxygen going through to the heart muscle at all. Don't worry, we're going to go through this a couple more times and then we're going to end with a nice summary. Okay? I promise. Just keep hanging with me. So ST elevation indicates ongoing cardiac ischemia affecting the entire wall. ST elevation indicates a more serious event. So these get worse as we move through them. So how do you know if it's unstable angina or a STEMI or a non-STEMI? Now, between a STEMI and a non-STEMI, that's easy, right? What do we look at? The EKG. But how do you know if it's maybe unstable angina or a non-STEMI? Or how do you know damage has occurred? How do you know we're at infarction and not just ischemia? What happens when things die in your body? They release enzymes, right? Things start to break down. We call these biomarkers. These are lab values. Do not worry about memorizing all of that. That's just to show you that at different points after the heart muscle dies, you start to see this increase in lab values. It will peak and then it'll come down. That's how we tell where you are in the process. Are you getting better? Are you over the hump? So what biomarkers do is they're released when tissue dies. So they're only released in infarction. So would they be released in unstable angina? Yes or no?
No.
No. So they're only going to be released in a STEMI or a non-STEMI. And which ones do we see released? CKMB and troponin. Troponin is a little bit more specific. In my day, when I was getting out of nursing school, we were all about the CKMB, and we still draw those. But now we get better stuff. As we get further in medicine, we get better stuff. And we find that troponin's a little bit better of an indicator. So if your patient comes in and they're having chest pain, not relieved with rest or not relieved with nitroglycerin, they're going to draw some labs. And they're going to run these stat, they're going to run them right away, and they're going to look to see if these levels start coming back elevated. If they're elevated, then we're going to look at, okay, is it a STEMI or a non-STEMI? And we can see that pretty quickly on probably the EKG tracing, or we'll run an actual 12-lead EKG and see it. And then we can decide, are they having a STEMI or a non-STEMI? And the reason we care about that is because we treat them different. A non-STEMI, we may stent or do something else. A STEMI will probably give clot busters and try to break loose a clot to reperfuse. So we treat them differently. This is what makes survival better. We have these protocols and evidence-based guidelines. If you have this, we're doing this. If you have this, we're doing this. And we make decisions quickly so that we can save heart muscle and reperfuse the heart as quick as possible. Now, CRP will also be elevated, but CRP is not very specific. It just says there's inflammation in your body, but it doesn't tell you where the inflammation is. And then what we do is if those levels start coming back high, we keep drawing them to see when they're going to peak. And then we can kind of start to see recovery. So they help us with clinical course. So an acute coronary syndrome, if we're having myocardial infarction, so that only includes STEMI and non-STEMI, okay? If the occlusion is complete and it goes on long enough, you're going to have irreversible heart damage and tissue necrosis. And when that necrosis occurs, you're going to see these biomarkers. We know that an STEMI, an ST elevated MI, it goes through the whole thickness of the wall. So that's a lot more problematic. And so we call that transmural. And so STEMIs are more transmural. I do not need you to know the treatments. These treatments here and here, I don't need you to know that. I just think a lot of times people want to know, well, why are we doing this? And the reason is because we will treat them differently. And then unstable anginas, no ST elevation and no biomarkers. So what are we going to do for that person? Send them home? No, these people are just waiting for problems. So we can't send them home. Okay? Their chest pain's not relieved with rest. And so any second they can go into a STEMI or a non-STEMI. So we're going to treat them too. We're going to run them probably through to the cath lab, figure out what's going on, see if we can open something up. And this is good because there's no damage yet to the heart. But we don't know. They could go into a full-blown STEMI or non-STEMI in any second. Now this right here, this DQRS, this is for later. But I put this here because you'll study later and you'll go back and look. This deep QRS is called a bundle branch block. And when we talk about bundle branch block, when we talk about dysrhythmias, we'll talk about a bundle branch block. And it usually occurs after a heart attack. And it shows that there's necrosis. What it is it's a QRS that is real wide and bizarre. Okay, it's real wide, wider than the 0.04 to 0.08. And what that indicates is that when the electrical activity is going down through that ventricle that's now damaged because it's been infarcted, it like gets stretched out. The electrical impulse gets delayed as it goes through that ventricle. So this is kind of for later, but I put it here because when you go back and study as a whole, you'll have all the information. It'll help you pull those together. So acute coronary syndrome, the majority of infarcts are on the left ventricular wall. Why is that?
Because that is the largest muscle.
It is the largest, so more chance. And it's served by the left coronary artery and the circumflex. So it's the bigger. Now, a right ventricular infarct, it's not great, but it's generally not quite as serious as a left ventricular infarct. If you have dead muscle on the left side, that's going to really impact your cardiac output, isn't it? Mm-hmm. Because dead muscle means it's never going to contract. It's just dead and scar tissue. So the ventricle's not got the same force that it has. When we look at these, wherever that the infarct, or wherever the plaque or the unstable plaque or the thrombosis or wherever the infarct is, let's say it's right here, then everything down here dies. That's a big problem, right? So we want to know the position. If the infarct is here, then just that dies. you see where who's going to be in more trouble? This one up here, because more die. So the further up it is, the more problems you're going to have, the more dead heart muscle. So everything distal dies. And here you can see a narrowing that occurs, and that's what we see on the cardiac cath. Now, at the time of the infarct, obviously the patient's going to have low cardiac output because the heart muscle's damaged, weak. They're going to be sick. They're going to be having maybe even fevers from the inflammation. We have all kinds of problems. Then, once we kind of get them over the hump, your body does heal, and things start to kind of pick up, and it starts to adjust to maybe not your whole muscle being able to function. And about 1 to 2 weeks after the injury, patients do start to feel better. However, the heart is still very weak. And that weak and dead area has to fill in with scar tissue and become a little bit hardened. Otherwise, it'll rupture. And so a lot of people, about 1 to 2 weeks later, they go home and they start to feel better, and they start to do more stuff. And that's a problem, because they do too much. So really by 6 weeks, that's really when a lot of our cardiac rehab starts. So as a summary, manifestations of acute coronary syndrome. It's going to be chest pain not relieved with rest. We start to see these weird pains, jaw pain, shoulder pain, back pain. I think this is so funny. This is just so typical of our health system. It says that atypical pain is more common in women. Anyone know why that is? Who is most of the data primarily studying?
White men.
Men. So I'm just saying that women don't have atypical pain. They have different pain. But a lot of times you'll read that in the literature. Women have atypical presentations. That's because most of the early research was done with men. And in fact, the IRBs now, for those of you who are in research, the IRBs make you say, if you're going to exclude a group of people, why? Okay, because, women, minorities, different groups of people deserve research based on them and outcomes based on them too. So you're going to see that atypical. And so it just means that it's different. Women may present differently than men. Nausea, vomiting, shortness of breath, epigastric discomfort. You've heard of all these before. These are your signs of chest pain. So we start to look at, we've got chest pain not relieved with rest. Then we look at EKG changes. Is there ST elevation or not? UA means unstable angina. Are there biomarkers or not? And that's how we're going to figure out what kind we had. Now, MIs can be silent, and we may see them later. How might we see them later? What does that mean? Like, how would you know? Like, later we would look at something and say, oh, you probably had a heart attack in your past. What might we tell us that?
EKG changes.
Mm-hmm.
Usually EKG changes, because the EKG will send electrical impulses down. And if you have a dead area from an old infarction, it'll be like the electrical activity will be a little different. Right? So here you go. Symptoms of ischemia, meaning chest pain not relieved with rest. And that's acute coronary syndrome. And so now we have to decide, what is it? So we look, is there ST elevation and biomarkers? You have a STEMI. If there's no ST elevation and biomarkers, you have a non-STEMI. If there's no ST elevation, no biomarkers, you have unstable angina. That's your summary. So what do you think I'll ask you? I'll give you a situation, right? And I give you some of these things, and you decide. Is it unstable angina? Is it stable angina? Is it a STEMI? Is it non-STEMI, right? I'll give you a situation. You figure it out. So afterwards, a clinical course, You will have some cardiac inflammation. Damage always causes inflammatory response. So it's not unusual for patients to feel yucky afterwards. Fever, inflammation, maybe fatigue because of heart muscle port, decreased cardiac output. And some of our biggest risks is these dead cardiac cells can cause dysrhythmias, which we will talk about, I think, next week or some point. We see a drop in stroke volume, so that means there's decreased cardiac output. Your heart compensates by increasing its rate. If you're not putting enough out, your body's not getting enough oxygen, and the first thing you see is tachycardia. Tachycardia is almost always a response to something going wrong. I think I told you this. Your patient's got a heart rate of 65 at 8 a.m. Patient come back at 10, your patient's heart rate's 72. You come back at noon, your patient's heart rate's 85. Those are all normal, aren't they? So what does the good nurse do, though?
Look into it.
Stands back and sees this trend and says, we're going in the wrong direction. Calls the attending. Something's going on. I don't know what. Something's going on. This is the trend I see. Attending comes down, helps you figure out, or you may know already, okay? So you have to start to notice, not just one point in time, but you have to start to stand back and look at the whole puzzle and the picture. Now, when your stroke volume decreases and your cardiac output decreases, why does the RAS kick in? Decreased renal perfusion, right? So the good nurse, not only do they see this heart rate going up, they look down at the Foley bag or they look at the urine output and like, oh, patient hasn't peed all morning. And what does that tell you? What about those kidneys? Are they getting good blood flow? No, because we know that decreased urine output is also a bad sign. Means something's not getting enough perfusion. Something's going on. So when you see tachycardia and you see decreased urine output, you should just love pee. I'm just telling you, when you walk in the room and there is pee there, you are happy. When you walk in the room, there ain't no pee. I'm just thinking to myself, this is going to be a long day, not only for me, but especially for the patient. This is not a good sign. Tachycardia and decreased urine output. If I teach you one thing today, those two things are not good signs. You should love urine. It's liquid gold. Okay? It just means everything's working. All right, 75% of MIs have complications such as dysrhythmias, shock, rupture, heart failure, inflammation, pericarditis. Almost all of them are going to have some of this stuff. Treatment. The goals of treatment are to increase oxygen or decrease myocardial oxygen demand. How can you decrease myocardial oxygen demand?
Make them rest.
Rest and oxygen. Okay, so these are the things we're going to do. We're going to try to get more oxygen, right? You're not getting enough oxygen to the heart muscle. Let's try to get more there. Give them some oxygen. We're going to have them rest so that we're not demanding. We decrease their myocardial workload. We make it easier for their heart. How can we do that? Why does decreasing preload make it easier for the heart?
Less pumping.
Less to pump, right? So we take some fluid off. Remember, preload is fluid. So how do we take fluid off? Diuretics maybe, or watch their fluid. If their IVs are going at 100 an hour, it might pull that back to 20. Okay? And also decrease afterload. What is afterload again?
The blood pressure.
Blood pressure. Why does decreasing the afterload help the workload of the heart?
Less pumping again.
Pumping as hard.
It doesn't have to pump as hard. How can we decrease afterload? Decrease what? Decrease our blood pressure. Okay, so we can decrease our fluid volume. We can decrease our blood pressure. And we can also decrease our heart rate, just so it's not going so fast. Pain relief, because pain increases your heart rate, increases your blood pressure, so we do pain relief. Usually it's morphine. Okay, usually morphine. But, like I gave you that example, morphine does have its drawbacks. It decreases your blood pressure a little bit. We may give them a pacemaker to help make sure what heartbeats go through are correct. We give antiplatelet or anticoagulant to bust up the clots or to open up, stenting or opening the artery. And sometimes we send them for a bypass graft. So the cabbage surgery is a bypass graft. We make our own collateral circulation. Okay, we take a vein from somewhere else and we sew it in there so it kind of bridges over that. Meds, these are your meds. I'm not going to get into these, but this just to help you put the two courses together. Cardiac rehab is important. About 6 weeks later, though, right? We're going to kind of watch, and we're going to look on lifestyle changes because we know we can do something about them. They'll start some exercise. Why would we start exercise? To develop what?
The laterals.
Yep, for collateral circulation. Nutrition, what would we focus on there? Decrease cholesterol. And what else? Decrease what?
Fat.
Sodium. Smoking is bad, bad, bad. Stress reduction, why is stress a problem?
Because stress releases your
Catecholamines, and it increases blood pressure, and medical management is sometimes the case. So some patients do have chronic ischemic heart disease. That's kind of that patient I was talking about who has maybe stable angina. Sometimes after a heart attack, patients will develop just their heart's kind of damaged over time and they can't pump as good. I mean, some people will have a big enough heart attack that it will impact the rest of their life. And they may not be able to go back to full activity. So that's just this chronic ischemic heart disease. Or they may be someone who's just over time has just gotten some stable angina and they just don't want to have surgery, or they're not good candidates for surgery, or their physical lifestyle is such that they don't really need the surgery because they're not doing much of anything anyway. These are not easy surgeries. We don't just put people, we're going to try to medically manage them before we send them to the OR. Sending an 80-year-old to the OR who doesn't have a whole lot of physical activity anyway, it could kill them, or the recovery could be just terrible. So these are people who maybe have stable angina, this Prince-Metal angina, which is a vasospasm. There's not a lot we can do for that. Like if your vessels are going to spasm, they're going to spasm. Most of the time we treat this with nitroglycerin. To just, when it comes, we just try to give them the nitroglycerin to vasodilate them. So this is just kind of the outcome. So a 76-year-old man came to the emergency department after experiencing chest pain while shoveling snow. What does while shoveling snow tell you?
Exercise.
Physical activity. Lab tests reveal normal SGOT, that's a liver enzyme, normal CPK, and normal LDH, that's a liver enzyme too. The chest pain was relieved with rest and nitroglycerin. What does this guy have?
And C.
It is C. Why is it angina?
Because it's
yeah.
ischemia.
It's not an infarct. Why is it not an infarct?
it's by rest.
It's relieved with rest and the CPK is normal.
Mm-hmm.
So that's your biomarker. In assessing a patient with chest pain, the nurse knows that angina is most often preceded by which of the following?
And it's fun.
What is going to trigger angina?
Physical exercise.
Yep, physical exertion. A patient with substernal chest pain in the left shoulder. Okay, so that to me sounds like angina. Short of breath, nauseated. That really sounds like angina. Heart rate's 100. What do you think about that? Tacky. EKG shows ST elevation, and blood tests reveal increased CKMB and troponin. What's this guy got? Yep,
STEMI.
he's got a STEMI. Okay. So, question?
No, I was looking at the photo. Let me look.
All right, for these next, we are going to use the map for a few slides, just because it's so boring to tell you the same things. So these next couple things are in the PowerPoint if you want to, keep doing PowerPoint, but let's go ahead. There's about 4 or 5 maps I have for this section. There was a cardiac map that just covered everything we did. So go home, try to see if you can fill that in tonight. We'll do that Thursday night, 8 o'clock, since that seems to be our night and time together. Okay? And then we'll also do the heart failure map on Thursday night. But in class today, we'll do this map, and then I think I have like one other that we'll do. So let's talk about some of these cardiac problems. Okay? Because that's what we're talking about, all cardiac disorders. So we talked about heart attacks. Now let's talk about some other things. So we have inflammatory things that can go on in the heart. We have effusion. Does anyone remember what effusion means?
Fluid
Yep,
collection.
effusion means fluid. Inflammation, effusion. We have non-inflammatory problems, and those are going to be cardiomyopathy, and we have acquired disorders, rheumatic fever. So those are our kind of 4 categories we're going to talk about for the next few minutes. So let's talk about myocarditis or cardiomyopathy. Does anyone remember when we first started, what did I say cardiomyopathy was?
Cardiac muscle.
Weak muscle. And it's usually flabby. And it's usually enlarged. Is bigger better?
No.
No. Bigger is usually less efficient. So cardiomyopathy is something that occurs when the heart muscle becomes very, very weak. You can have inflammatory or non-inflammatory. Inflammatory means a virus or something causes it to become weak. Non-inflammatory means it just becomes weak. When we talk about the difference between myocarditis and cardiomyopathy, myocarditis is usually inflammatory in nature, but we're going to talk about these things together because they end up the same way. Myocarditis or cardiomyopathy is a weak muscle. So if the muscle is weak, what do you think some of the manifestations are?
Decreased cardiac output. Low.
Decrease cardiac output, right? If the muscle can't pump, you're going to have decreased cardiac output. Did the pre-lecture talk about ejection fraction? Yeah. What is an ejection fraction?
The heart pump out the blood.
It's how much blood the heart's going to pump out, right? And what should your ejection fraction be?
70.
Should it be 100%? No, it can't pump out everything. So a normal ejection fraction is somewhere about 60 to 80%. You guys are all 80%. I'm probably down in the 70s, okay? Just over time, gets a little less. We start to worry when ejection fractions start to get down less than 60%. And when we have a weak heart muscle, what do you think the ejection fraction is in cardiomyopathy?
Lower.
Yeah, it's down. It's going to be less than 60. So we have not enough blood being pumped out. You can all just imagine what the issues are if your heart's not able to pump enough. Okay, you don't get enough output to your body, you get short of breath, okay, you're fatigued, you have malaise. We had a faculty here a couple years ago that ended up getting cardiomyopathy. We think it was from a virus that just attacked her heart. And it just came on. She just started getting tired and short of breath. She went in and boom, she had cardiomyopathy. Sometimes it just happens. And her ejection fraction or cardiac output was so low, they had her on an external defibrillator. And she was back at work, and it just made me a nervous wreck. I was like, seriously, you couldn't just like take some time off? She's like, well, I don't know how long this is gonna go on. She recovered some, but the worst problem with cardiomyopathy is you tend to not be able to recover. Some people will pick up some of their cardiac output, but your heart takes a pretty big hit. So what do you think the solution is for cardiomyopathy in a lot of cases?
Pacemaker.
Transplant.
Oh.
Okay. So if you hear that your patient has cardiomyopathy and it's not resolving in a few months, then they're probably going to be listed for a transplant. Okay. It's just a weak heart muscle that cannot function. So when you have inflammatory cardiomyopathy, that would be myocarditis, and that's usually from a virus or something. Regular non-inflammatory cardiomyopathy, there's a couple different kinds. There's one called dilated. There's one called hypertrophic. And there's one called restrictive. Dilated means that it's enlarged to the point where the walls are very thin of the ventricle. They're stretched out. If you take elastic and stretch it out to where it's really stretched out, how much contraction is left in it? Not much, right? Mm-hmm. So that's what happens. The walls get very, very thin, and it's overstretched, and it can't pump. Hypertrophic means that the walls are too thick. Sometimes the wall of the heart muscle just gets thicker and thicker and thicker and thicker. Well, what that does is if you have a ventricle, so this is your heart, and you have your 4 chambers, and if the wall is really thick, do you see how what's inside the ventricle is very small? Does that hold much blood? Mm-mm. No. So when you get the walls too thick, you have decreased cardiac output too. And then restrictive is stiff, fibrotic. Things like sarcoidosis, lupus can attack the wall and make them stiff. If they're stiff and rock hard and not elastic, do they contract? No. So there's different types, but the key is all of them become a weak heart muscle with decreased cardiac output, and you have symptoms related to that. To me, that's the most important thing that you need to know about cardiomyopathy. Sometimes women postpartum will develop cardiomyopathy. Okay? It is scary. It will happen within 6 months of delivering a baby, and sometimes they can develop postpartum cardiomyopathy where their heart becomes weak. Because if you think about it, while they were pregnant, that was an extra load on that heart muscle. So you will talk about that in OB, but I'm not going to spend a lot of time on cardiomyopathy. Just it's a weak heart muscle. It has poor cardiac output. And if it doesn't resolve in a few months, you're going to be listed for a transplant. So you can have inflammation in your heart. If you have inflammatory cardiomyopathy, we call it myocarditis. And that is some kind of virus, usually, that causes the heart to become inflamed. And if it becomes inflamed, it's going to have poor cardiac output. The other inflammatory process that we see is called endocarditis and pericarditis. What's the difference between endocarditis and pericarditis?
Which layer of the heart is infected?
Inside
It's
and
the layer of the heart. So this is inflammation inside the heart. And this is inflammation on the covering or the outside of the heart. So endocarditis, so you got something causing inflammation inside. How does something cause inflammation on the inside? Where would that source be? What's inside the heart?
veins.
No.
What flows through the heart?
Blood.
Blood. So what could cause blood to inflame the inside of the heart? What do you think?
Bacteria, pathogens, and
What causes infection? Yeah, pathogens.
pathogens.
Yeah, infections. Pathogens. Have you ever heard like your mouth, like dental health is like so important for heart? Okay?
Mhm.
People who have really poor dental health and poor teeth, they actually have a lot of cardiac inflammation and a lot of inflammation in their body. Okay? There's this direct connection between microbes and stuff gaining access to your bloodstream. Who else is probably at risk for developing infections inside their heart? Who's high risk for getting blood infections? Immunocompromised. Drug use. Okay, IV drug users often present with endocarditis. Okay? Because they're injecting and it's usually staph or strep that's on the outside of your skin. Most people who are have good immune systems don't develop that unless they have high loads of bacteria in their mouth and poor dental health or IV drug users. And if you think about it, if you get infection inside your heart, what does it maybe start to aggregate on and ruin? What's inside your heart?
Valves.
Valves. And if the valves aren't pumping well, then you start to have, decreased cardiac output. Because it's inflammation, you have fever. Okay. Now, pericarditis is the inflammation of the covering of the heart. And we actually we just had a little talk in the first hour about what causes inflammation of the covering of the heart. What is the biggest cause, you think? What did we just talk about for like 30 minutes? Angina, acute coronary syndrome. So when you have a heart attack, remember that causes inflammation?
Mm-hmm.
And we often see a lot of pericarditis with that. So what pericarditis is inflammation of the covering or the outer layer of the heart. And MI, myocardial infarction, acute coronary syndrome, is usually the biggest cause. But it could also just be from trauma, okay, other traumas. What patients usually complain of is pain. And so you start to say, well, what's the difference between chest pain and pericarditis pain? And that's hard. That's hard to figure that out. The patient comes in, they say, I have chest pain. Well, we work them up the same way. Okay, we put them on the EKG. There's no ST elevation. We draw troponins and CKMBs, and they're not high. Okay? And so it could just be some inflammation. You can just get inflammation of the heart. Sometimes, you got a little infection, or maybe you've had some trauma, or something like that. So pericarditis is not unusual. If it's not related to a heart attack, there's not a lot we can do. We'll give them some aspirin, ibuprofen, anti-inflammatories, tell them to rest and see if it resolves. So pericarditis, sometimes you'll hear a friction rub when you listen to their heart, and you'll just hear that there's just like some little bit of swelling there, and you can hear it's just not real efficient, and they'll have some pain. But we have to tease it out, because pericarditis alone isn't really a big problem, but we have to make sure they're not having acute coronary syndrome.
So what type of trauma can cause that?
Oh, I don't know. Let's say you're in a car accident and you hit the steering wheel with your chest.
Oh.
Something like that. Effusion. We said fusion is fluid collection. So pericardial effusion, what do you think that is?
On the outer
Pressure around side.
around the heart.
Yeah, so your heart has the covering, and inside is a tiny bit of fluid to help with movement. Okay, fluid helps lubricate. That's what the word I'm thinking about. And so sometimes with pericarditis, even you can get too much fluid accumulating in there. So it's just accumulation of fluid in the pericardial sac. So if this is your heart, and then you have a little bit of covering of your heart, and there's normally a little bit of fluid in there, but let's say what we have is you have your heart, and then you have too much fluid in there. Okay, you get too much in there. So what do you think about the heart? If this is a cross section of your heart, what do you think about pumping and cardiac output, and what do you think happens to this heart muscle if we have too much fluid in here?
It won't let it.
It's hard to compress and it's hard to beat. So a little bit of effusion is just going to maybe cause some little bit of chest pain, and it's probably more like pericarditis. But when we have this much and a collection, we run into this problem called tamponade. And so can this heart beat when it starts to get this collection?
Mm-mm.
No. So we have decreased cardiac output. What do you think would cause this much fluid to collect in here? That's a lot of fluid. What do you think would cause that much fluid to collect in there?
You get stabbed in the heart.
What?
If you get stabbed in the heart.
If you get stabbed in the heart?
Mm.
Trauma. You watch any of those ER shows? You all do, right? Because you want to be a nurse. And you hear, and they've been in a gunshot wound or a severe chest injury. And they come rolling in and there's no heartbeat. Or the heartbeat's real minimal. And they yell, tamponade! And everybody goes running and they get this big syringe. And they literally just stab it in the heart and blood squirts out and the heart starts beating again. Okay, it's a little dramatic, but that's kind of what they do in those ER shows. So this is usually from trauma. And what we see is basically so much decreased cardiac output because the heart can't fill. So it's a severe effusion. So much so that your heart can't pump. And so if you don't release all that blood, you won't have a heartbeat. You'll die. So effusion can be mild or it can be severe.
So with
tamponade severe.
Yep.
So with
Yeah.
mild, they don't do anything.
Probably not.
Okay.
Probably not. They're going to give you some anti-inflammatories, tell you to rest, keep an eye on you, and hope and pray. You know, we love time. There is something to that saying time heals all wounds.
Mm-hmm.
Time really does. I mean, think about it. When you're, hurt yourself or whatever, you give it a little time. Your body is fabulous at just taking care of itself if you give it a little rest and give it a few things that it needs. So tamponade would be the most severe form of carditis, of pericarditis or pericardial effusion. Sorry. Last one, then we're going to take a quick break. One acquired disorder we're going to talk about. Rheumatic fever. Who's heard of rheumatic fever? Okay. And who knows what the cause or the etiology of rheumatic fever is?
This virus.
Strep. Good old strep throat. Not everybody that gets strep throat is going to get rheumatic fever. But there is a risk. And, you all got a good, healthy respect for strep, right? Strep in and of itself, the toxin that it releases, is usually much more severe. Patients who have strep infections, I'm more worried about than patients who have staph infections. Even MRSA, I'm like, eh. But strep has this thing where it releases a lot of toxins. Strep is one of the nastier bacteria or pathogens that we have out there. So strep infection, and it's the beta hemolytic strep, the one that causes strep throat, is the etiology of rheumatic fever. And years ago, when we didn't have good access to penicillin and treatment for strep and quick tests for strep, we saw more rheumatic fever. Do you really hear of rheumatic fever much anymore? No, not unless you go to countries who don't have access to health care. And then you're going to actually see a lot of outcomes of rheumatic fever. But because we can do quick old strep tests and, amoxicillin, penicillin's cheap, we can treat you for $5, we don't see a lot of it in the United States or in developed countries. So what happens with strep? Well, the pathogenesis is basically what we have is it's an incompletely treated or a not treated strep infection. So someone who didn't finish their antibiotics, or someone who took them but it just didn't clear it, or someone who didn't get treated at all, is now become at risk for strep, or at risk for rheumatic fever. It doesn't mean they're going to definitely catch it. It just means they're higher risk for it. And what we see is the strep toxins that are released by the bacteria will end up causing scarring of technically the endothelium, or the inside of the heart, the endocardium. Now, what is the big structures on the inside of the heart that we're really talking about? Valves. So that strep that's circulating in the bloodstream starts to attack the valves in some people. Valves should close tight, but what happens is these toxins build up on the edge of the valves. And we call that vegetation. And so those valves don't close well, and they start to leak. The manifestations, there's a lot of different manifestations. There's things like joint pain, because the strep is circulating through your body, so it's affecting everything, so it's systemic. So we see some maybe joint pain, we see a rash, we call it the scarlatina rash. Has anyone ever had scarlet fever? That just means you had strep and you actually had the rash. Sometimes you make the rash, it's just like a red sandpapery rash. We see carditis, which is just inflammation of the heart. We're going to see increased antibody titer. We're going to see increased sed rate. And that's how we're going to know that they have rheumatic fever. And our big worrisome is the development of valve damage. Meaning leaky valves. And we're going to talk all about leaky valves after the break.
Can this be treated, obviously?
Yeah,
Just more
so if
violence.
we know that you have it, we're going to retreat your strep with the antibiotics. And there's some other things we're going to do, like aspirin and other types of treatment and rest. And we're going to monitor your valves to see. And if by chance you do develop valve damage, what are we going to do with those valves if they're bad enough?
Replace it.
Yeah, we can replace them. But what we see is a lot of times if you go do, a lot of times people will do like global brigades and go to other countries and provide health care. You'll see a lot of people that come in that have had heart damage from rheumatic fever, and they'll have leaky cardiac valves, and a lot of times they'll go down there and do some valve replacements and stuff on them. So that's the risk of it. So hang on one second. So the take-home message here is, if you think you have strep, do what?
Treat it.
Treat
Scan
it.
it.
Yeah, treat it. What was your question?
What is SEM rate?
Sedimentation rate. ESR, it's a lab test that shows inflammation.
Okay.
Good question.
What is the difference in, we just talked about CPR, C something?
C-reactive protein is a
And-
general inflammatory marker. Sedimentation rate, ESR, is another one. These general inflammatory markers, they tell us there's inflammation in the body. It helps us go look for more specific. So they're general tests.
So
If they're
can-
elevated, their
Yes.
inflammation's present.
So
Yes.
can you also use CRP for this?
Yeah.
Mhm, probably.
Okay.
Yeah. All right. So there's not a lot. I mean, these aren't hard stuff. Basically, we talked about tamponade was kind of important. We talked a little bit about the biggest etiology and what goes on with that. And we talked about what, in general, myocarditis was. Those are probably our biggest things off of this. Okie doke. Let's take a break. Come back about 9:30.